I would like to now invite Professor Aditya Goyal. I think he doesn't need any introduction, and without wasting much of the time, I've just put up a slide about all his achievements and all his qualifications and present positions. And presently, he is at Sankara College of Optometry as a principal, mentor, adjunct faculty, Philadelphia, member of MOHFA, FW, and is the president of Association of School and Optometry, College of Optometry, India. Over to Professor Aditya Goyal.
Thank you so much, Dr. Chaudhary. Uh, Good morning, everyone. Very interesting and a very different experience to be speaking to so many audience today. But then, all the same, it's very interesting. I'll be talking a bit about practical tips in vision therapy. In fact, Pooja has done most of it for me, so she's made my job a lot easier. I'm practically going to repeat most of the things that she mentioned. First thing to begin with, we all call it CVI, or cerebral visual impairment or cortical visual impairment. But I think we need to differentiate between CVI and DVM because the prognostics are very different between the two. In CVI, the prognosis is not that great, but DVM prognosis is very, very good. So we should look at the delayed visual maturation and differentiate it from cortical visual impairment. And pupils narrate all the story. You look at the pupils, and from that you can make out whether it is CVI or DVM and how the prognosis is going to be. First thing we need to remember, move from ability to inability. Do not start working on the things that the child cannot do. There's no way in which, whether it is vision therapy or anything, I think the first thing we should work from is what the person is able to do and then go over to the things that he's unable to do and do not jump it. Protocol that should be followed depend upon the visual abilities that the child has. So like Pooja mentioned, you have to measure all the abilities, whether it is the visual acuities or the contrast sensitivity, eye movements, etc., etc. And then depending upon where the child is, start proceeding from there. Now, most important thing, the person who the child relates to maximum, the baby relates to maximum is the mother. The therapy ideally should start from mother. We as optometrists or therapists or whatever, we may give adjunct therapies, but the most important thing, most important therapy is provided by the mother. So we always tell the mother to hold the baby like this, wear very bright clothes, have a big bright bindi, and keep talking to the child, because that becomes a very important thing, because the child is used to the mother, child is used to the mother's touch, child is used to the mother's voice and language. So ask the mother to speak to the child as much as possible, looking straight into the eyes. The baby may not be responding, the baby may not respond at all, but that is most important. Now, from our perspective, if there's no perception or very poor perception of light and no fixation, follow the steps ahead. Or if there's perception, if there's perception of light, if there's fixation, then take from where we go now. So the first one, like Pooja mentioned about the light stimulation. Caution over here, sometimes when the child has seizure disorder, please do not use flashlights, though a few neurologists say that it's okay to use flashlight and they will manage the seizure. But then I would have it as a word of caution and not to introduce flashing lights, because they are contraindicated. It may induce seizure disorder. Use LED lights, light emitting toys, etc., etc., and continue until there's some semblance of perception of light and there's some amount of fixation. Again, keep a watch on the pupils. We use this floor rotator considerably. So what we do is we fix light on that, a torch light or a small LED light, and rotate it at a very, very slow speed. Keep it in a dark hall, dark room, and rotate the floor rotator at a very low speed, and the child needs to follow that. So the brightness of the light could be increased or decreased depending upon the perception, depending upon the fixation. And if the fixation is not good, stop it. Keep it stationary till the time the child starts fixating, and then start rotating it again. The next we work on is the light emitting toys. So you'd seen a video when Pooja was presenting. So make sure there's no sound in the toys, because the child may get attracted by the sound and then look at the toy or follow the toy because of the sound. Please do not have the toy making any sound. Have only the light. Move them very slowly in front of the child, because the child is able to perceive the movement, and if it is too fast he may not be able to perceive it. So move the toy very, very slowly and see that the child is maintaining the fixation. If the fixation is lost, go back to the primary position and start moving it again. Introduce patterns. So we have plenty of patterns like that. It could be in form of paper patterns printed on paper. It could also be made as a PowerPoint presentation or some kind of software, and that can be presented to the child. And again, look for the fixation, and once the fixation improves, make the pattern as intricate as possible, because initially it is large, huge patterns, and as the fixation and the perception improves, keep on making it as intricate as possible. So I have made a small, the bold one and a slightly intricate one besides that. Once the black and white patterns are perceived, introduce colors. I like to put the red and the blue, or the red and the green, because these are two different parts on the different areas of the spectrum. So that is the reason why we introduce the red and green or red and blue. And you could also introduce filters, the red and blue filters, which make the perception of color as well as perception of the objects possible. Look for the fixation with each eye and continue until constant fixation is achieved. Then we use the rotator like that. So as you can see, it has white, green, and red objects made in that. So you could use anaglyphs, that is the red and the blue glasses or red and green glasses, and then track the eyes. We like to use a lot of mobiles, so we use slow moving videos. Fixation is definite at this point of time. Introduce very slow movement of the video. Take a mobile or maybe on a tablet, move it very, very slowly across the visual field of the child, and see that the child is able to follow that. Once the child is able to follow in a linear manner, start rotatory motions. And once the child is able to do that and maintain gaze, maintain fixation, then a zigzag movement and other movements and the faster movements can be introduced. Introduce big toys with no light and encourage them to reach out to the toys. Initially, we are only looking at the fixation, the eyes, whether the child is able to perceive it, look at it or not. Once all that is there, start reaching out. The eye-hand coordination has to improve. As the child is able to see the big toys, please reduce the size of the toys and keep on going till the time the child is able to look at the smallest possible toy and able to fixate it and follow it. Introduce movements and look for accuracy of fixation, maintenance of fixation, and accuracy of reach. The child should be able to reach out perfectly well and hold the toy. As the movements improve, keep on making it intricate, and the child should be able to fixate and reach out accurately. Like Pooja mentioned, you could introduce softwares like Senate Vision Integrator, VisuPrime, etc., etc. Lots of softwares are available in the market today. The speed of the rotation can be changed. They all come with touch screen, so the child is encouraged to touch the object and see it vanish. So it's a big game for them, and the size of the rotating dots, rotating objects, rotating alphabets, all that can be introduced over here, including contrast and color. Once that all is achieved, start working on binocularity, because that is one very important thing that we work on. Stereo depth binocularity, that is the ultimate thing that we work on and work for. Look for tropia if the child has a tropia. Introduce binasal patch to initiate peripheral fusion. It's a wrong perception that the binasal patch is going to push the eye out and it can be used only in esotropia. It's not so. It is to induce peripheral fusion and not to push the eye out or in. These kids have very centralized viewing, and that has to become more peripheral because that is most important in binocularity. Introduce translucent patches in case of tropia. I am for one against total occlusion where you put an opaque patch. I would like to use Bangetta foils and translucent occlusion, like the case, like the child over here. A good objective refraction is required and prescribed glasses in case of significant errors. And they can be prescribed binasal patches to encourage peripheral fusion and binocularity. And that needs to continue till the time you're perfect with it. And invariably, we do not reach these levels in case of cortical visual impairment, but delayed visual maturation, absolutely yes. So thank you so much for your attention. We'll be happy to take questions.
Thank you so much,
Thank you, ma'am.
Professor, for your wonderful talk. Now, one question that I have is how, when you are having a child with a CVI, when do you reassess the child? And supposing it's a very gross CVI, when do you reassess the child after the whatever best therapy that you have given?
Sorry, can you repeat the question?
No. Uh, for example, you have a child with a severe CVI, cortical visual impairment, and you have given the best therapy. Okay. And when do you reassess the child? I mean, whether the therapy is, working well, or how frequently you do the reassessment? Is it on a daily basis or monthly basis?
We like to reassess the child on a frequent basis, but then the therapist knows exactly where the stage is, and based on that, we continue. So, ideally speaking, I would like to reassess every 2 months or so, but then, in case the child is not improving at all, then probably more earlier. And if the child is improving more, then again we make it more frequent.
And when do you, feel that the child should be referred to the ophthalmologist? When do you think that the child should be referred to the ophthalmologist? How frequently will the ophthalmologist intervene? Maybe
Difficult
once.
question to answer that, but then uh, see, it's a kind of inter-professional relationship, and I personally, for one, do not believe in doing vision therapy alone. We work along with other therapists, for example, physical therapists, occupational therapists, speech therapists, especially. We like to work along and perform the therapies together rather than do it solo. So that I felt, and what I feel is in our clinic, we have the physical therapists, we have the occupational therapists, we have the speech therapists who are working along at the same time on the child. That brings much better results as compared to
Yes.
solo therapists working.
Yes. Yes. Thank you very much. Thank you.
Thank you, ma'am.
Yeah.
Doctor,
Yeah.
is there any specific this thing that you do for optic ataxia, where vision by itself may not be a problem, and is there any particular therapy that we can do for that? And Usha, I think ophthalmologist should see the child if the child is not improving.
That's what
That's
I
all.
wanted to understand
The
from
routine
Professor.
checkup once a year, if there may be enough.
I think
But
that may not be
if the
enough.
child is not improving,
Yes.
Then
Yes.
both the neurological as well as re-evaluation of ocular status and all that also has to
Yes.
be
Yes.
reviewed,
Yes.
because there may be something else which is preventing.
Right.
And of course, if you have to give prognosis to the parent, then it becomes
Yeah.
important.
And then the
See,
best place.
unfortunately, ma'am, most of the ophthalmologists do not understand the difference between
Exactly.
eyesight and vision.
Yes, that's
Yes,
exactly the
yes.
reason we are here.
That
And
is very true.
yeah, and that's the
One more
reason we are
point
here.
on this, that we at Narayan Netralaya, what we do is we first it goes to ophthalmologist only, and then it comes to us, or sometimes it comes to us and we will send it for opthal opinion, because mainly our CVA is checked by Dr. Anand Vinayakar, pediatric retina. He performs specifically a OCT scan, and in this OCT scan he shows the CVI marker in OCT, and every 3 months when he is repeating the CVI markers for OCT, and he's showing exactly the layers are developing. So that's how we do.
Yeah, I think that's an excellent way of doing it, and
Another
that's the
thing,
reason why we should have an.
another thing very unfortunate is whenever there's a visual, the eyesight is low, optic disc always seems to be pale, which actually not the reason.
Right.
We are not able to differentiate, we are not able to find out, and we just mention optic displacement or optic atrophy where it need not be the case.
I,
And
I, I,
we discount the neuroplasticity, we discount the possibilities that can always be there, and we send the child to a blind school, and that's the end of it.
that's true. Yeah, it's an unfortunate thing,
Sir, I have a
and
question regarding the toys which you have mentioned that sound should not be there.
yeah,
Sorry?
Regarding a bright toys in which sound should not be there, you have mentioned, right? So, wouldn't a audio visual feedback loop present in our brain help in kids for developing visual maturation
Yeah,
faster?
see, in case it is leading to some perception, yes. But what I had introduced was, what I had told was the time when the child has started perceiving. At that time, I'm not concerned about the auditory feedback.
Yeah, yeah.
I'm more concerned about the visual
Yeah.
feedback.
So, can we initiate with that, then remove that
Yes,
audio
yes,
audio
yes,
cues?
yes.
We can do that, right?
Yeah.
Thank
Thank
you.
you.